Well,
Meade.
welcome everybody. I'm going to kind of multitask as I let people into the room and do some introductions. But my name's Michael C. I'm kind of on the program planning committee for MIMed. For those of you that aren't familiar, MIMed is it's kind of a loosely organized, non-exclusive interest group focusing on integration of motivational interviewing in healthcare with excellence. And this group works include MI as part of a standing healthcare training. Our new website is designed for MI providers and trainers who focus on healthcare training and practice. And for those in medical professions, MD, allied health professionals who have an interest in learning about motivational interviewing and the positive impact it has on patient care. And so we do MI Med Stories bi-monthly. We take the kind of the summer off, but we're back. And we'll let Stephen, our kind of leader, say a few words if he'd like to. Stephen?
Just a word of welcome. First of all, thank you, Michael, for directing and organizing us. Thank you, Jan, for appearing and talking. Thank you, the group. I recognize most everybody, not quite everybody. Thank you for joining us. It's exciting and fun for me to see this grow. The website is new and will be developing. We do have actually a very skilled a web provider now and colleagues who will be uploading all these recordings. So right now, if you go to the website, there's only one, but we've got an archive of about 20, and we'll be adding as Michael in this group contributes. So that's all I want to say right now. And we have in the alternate month, we meet as a ad hoc planning group. So those of you who are interested in joining and building with us, our meeting will be in the second Monday in November for the building part.
Yeah, and so you can go, I'll share in the chat our link to our website. We can go join up our registry and receive communications from us about, activities and programs. So let me just introduce our presenter. She's a friend and a colleague, and so I'm grateful that she's joining us. Jan Kavorchin is Associate Professor of Health Outcomes Research and Policy at Auburn University. She's has been in behavior science, focusing on outcomes research with nearly 25 years of experience applying an adult learning theory basis for motivational interview training for practitioners across health profession, and teaches advanced MI electives to pharmacy and PhD students. She's trained over 3,000 practitioners, healthcare professionals in the area of motivational skills, motivational interviewing skills. Her research includes outcomes for disease management intervention, particularly using MI for self-management behaviors in diabetes, obesity, and chronic diseases. And so I'll pass it off to Jan. She can tell a little bit more about herself, and then she'll get started. This is being recorded. If you do have to leave, we can. This will be available to you. So I'll leave it to you, Jan. Thank you for joining us.
Okay, I hope you can hear me. Volume loud enough.
Sounds good to me.
That's great. Well, I am very honored to be invited to share with you all for a little while today. I have a passion for the topic I've been asked to talk about, and that is primarily my experiences in motivational interviewing training. I wasn't sure if some of the people who would be joining might have seen, motivational interviewing and thinking that it's about, an actual training and an overview. That's not the purpose of what I'll be doing today, although I have interspersed in here just a couple of select places that I will go kind of step out for a second and just show you a few slides to cover a couple of select topics that I'd like to talk about. Because I'll be presenting from my experiences training healthcare professionals, but also health profession students, primarily PharmD, and some interprofessional PhD students as well. Let's see, there was one more thing I was going to say about that, and it just absolutely slipped my mind. So I'm going to go ahead and pull up the slides and get started there. It'll come to me. Okay. Okay. Um, so just a few things to disclose about some of the things that I'm doing in this space, but just kind of moving along in the interest of time. I'm going to talk a little bit about background and about these diverse training context experiences. And I remembered what I was going to say a moment ago. And it was that over the course of this 25 years almost of training healthcare professionals across professions, I have about 3,400. I have learned a lot about where the challenges lie. And I've come to realize that there really is a communication culture in healthcare, which in a lot of ways is still continues to be MI inconsistent, if you will. So I'm going to highlight some of the things that I've learned along the way in that regard and tell you a little bit about how I address that in the training that I and my colleagues do. So I'll talk a little bit about MI training philosophy in this population, training highlights and structure, both with healthcare providers and also with students. I'm very incredibly pleased and grateful that I'm in a setting that is pro MI teaching and training in the curriculum. I've learned also that that's not always the case. So I feel very fortunate to be able to really deliver that in a very evidence-based way across the curriculum. And then we also have a focus in assessment of MI skills, both in the student realm, but also sometimes in the healthcare professional realm. So I am at Auburn University and actually got my degrees here. PhD was in health psychology and behavior sciences, but I also had some focus in adult learning, educational psychology, interpersonal communication, and I also have an MBA with a focus in marketing and consumer behavior. And you may be thinking, what does that have to do with anything? Well, there are just some things that I learned along the way in that realm that I also engage into my MI training, because there really are some parallels between consumer behavior decision making and patient behavior decision making. And so I had my first faculty position at West Virginia University, not far from Gary, over there in Morgantown, West Virginia. And that was a phenomenal experience. You may not think that about a place like West Virginia, but that university was very well funded, very robust health sciences center. I know they're having some challenges now. But at the time that I was there, it was a top 5 in the country outcomes research program. And they sent me to Harvard School of Public Health to their week-long Outcomes Research Institute, where I learned really interestingly a great depth and breadth of the spectrum of outcomes research. And so currently I got recruited back to Auburn. Didn't plan for that, wasn't unhappy there, but both of my daughters were in college at Auburn at the time that I came back, and my whole immediate family had moved to the area, and I just couldn't resist the opportunity for that family time. And the department here, which has always had a robust graduate program, was really making the transition to an outcomes research focus. So I was pretty excited to get a chance to be a part of that development, having come from WVU. So a lot of what I do, most of what I do, is in diabetes and related cardiometabolic conditions and in adult populations, both in the teaching and the training of it. But I do also do some teaching to the students and being prepared to talk not only to the patient, but the caregiver. And sometimes that means a parent of a child or youth. And so at one point I got funding to take my technical MI training for healthcare providers and convert it to a lay level MI training for parents of youth with type 1 diabetes. And that has been a very rewarding experience in my professional life, and I disseminate that freely with a few initiatives that I have going on. And I have several other things, a little bit in cancer, a little bit in substance use disorder, that I've done some teaching and training. But I also do teach in the PharmD curriculum. Again, I'm not a PharmD, I'm a PhD. So I am teaching this content in the PharmD curriculum here, as well as in our PhD program. So we have a pretty robust PhD program. And the course that I teach in MI, the advanced MI, is very interprofessional. We draw students from other programs like clinical psychology, nutrition and dietetics, and especially kinesiology. We've done quite a few things with their PhD students, and I have been on the dissertation committees of a few of those as well. And so I also co-teach in some of their courses, the ones you see there in that second bullet. And I also have a lot of experience over time coming to speak or full consulting with other schools and colleges of pharmacy for motivational interviewing, curricular integration, and MI training of their faculty. So I've learned a lot from seeing these other perspectives, but also helping others get started from the ground up. And actually a couple of my proteges, Cedarville University and the University of Houston, really have taken it and run with it. And I'm very proud of their accomplishments in MI training with students and PhD students. So my diverse training experiences, meaning training delivery, started with just simply some early motivational interviewing talks, even while I started my career at West Virginia University. The American Medical Group Association, American Pharmacists, ADA have several years of experience and invited back doing what I would call an MI mini workshop, if you will, at the ADA clinical conferences for about 4 different episodes of that. And I continue to do some things in MI training for ADCES, American Association of Diabetes Care and Education Specialists. So this is training people who are in diabetes self-management, education and support programs, and or diabetes prevention programs. Also early on did some consulting for MI training on research grants, NIH, including NIDDK, CDC, and a couple of HRSA grants. I also have diversified this training into motivational interviewing and academic detailing. So if you're not familiar with academic detailing, because I'm not really sure exactly who I'm talking to, but if you're not familiar, it is using the evidence base to talk with healthcare providers across professions, but it's usually a primary care provider, usually prescribers, physicians, nurse practitioners, PAs, and others who are going to be facing professional behavior changes like prescribing, referring, screening, or counseling. So I've done projects for West Virginia. I've continued to go back probably about, I've been away from there for 19 years. And yet I've gone back probably about every other year with an ongoing consulting stream in the academic detailing. So most of that has been training pharmacists to talk to prescribers about opioid prescribing, as well as stimulant prescribing for people presenting with ADHD-like symptoms. And then also for Texas in the substance use disorder space, and for the VA, the Veterans Administration here in Alabama, and most recently academic detailing for MSLs, for a medical science liaisons for a pharmaceutical company. So most recent, I guess, that I'm very honored and excited to report is I've been named MI Training Subject Matter Expert for the CDC's 5-year, $20 million umbrella grant that includes 77 DSMES and DPP sites, or state departments of health. And as I mentioned, I've trained over 3,400 healthcare providers and probably about another 3,700 PharmD and PhD students. So I really have learned a lot in this process, and I get very excited when I get the opportunity to tell you about some of the things that I've learned. So I have some training philosophies that kind of undergird everything that I'm gonna say from here on out. And it's no surprise to you, the first bullet, I'm guessing. It's not a surprise. Healthcare providers and health profession students, for the most part, will have no or minimal background in counseling and psychology. So I'm guessing you're aware, most of you, maybe some of you aren't, that MI got its start over 40 years ago in the counseling and addictions fields. Miller and Rolnick, William Miller and Stephen Rolnick are touted as the originators of motivational interviewing. And they really had good success with it there in that realm. And we began to see MI emerge in the healthcare literature, really beginning to emerge really in the 1990s, propelled forward by some landmark studies and systematic reviews. Ruback and colleagues in particular in 2005 put out that wonderful systematic review and meta-analysis that really made the case for MI when appropriately trained and applied. So I am aware that most healthcare professionals in today's environment do not come into an MI training with all of that background that those from counseling and psychology would have. All of that practice and supervision and feedback and coaching is not typically part of their background. And in fact, probably about 10 or 15 years ago, I did a study of schools of pharmacy and medicine, little survey project, just looking at what they're doing in MI. And it was really very minimal. So I've never forgotten that. And so my philosophy there is keep it simple. We may not use all the technical terms. We may not go deep on some of the really important concepts, and I'll tell you about that as we go. Just trying to be concise as well. I don't really focus on Miller and Rolnick's acronyms, even though I incorporate all that into the way I teach and train this pretty consistently. I'm not going to bombard them with trying to remember these acronyms and what's what, because quite often I may just get one training in with them. I may not see them again. I may not have follow-up training with them. So I use MI to teach and train MI. I think that's really very important. I mean, if you think about it, when you're training a healthcare provider who comes from this healthcare communication culture that we have in our U.S. healthcare system today, we're really asking them to make some changes in their professional behaviors, in their communication strategies. And it represents big change for a lot of people. And it can be a vulnerable thing for healthcare professionals, especially if they didn't choose to come to that training. I've done some trainings where, everybody in this department is going to go for this training. And that can be challenging because maybe not everybody is on board and wants to be there. But I've done more training where they're opting in and they're there because they want to be and they want to expand their skills. Either way, I'm going to use MI to teach and train MI. And that means I'm going to explore with open-ended questions. I'm going to support self-efficacy in the process that we engage for giving feedback and coaching at the end, as well as things that they may say or do along the way. I'm going to express empathy if I hear frustration or excitement. I'm focusing on small change, supporting autonomy and flexing when that needs to happen to help support group dynamics with this particular group. I really I really want people to come away feeling encouraged and not discouraged. So I'm all about creating a comfort level in that group because the role play we do it in a small group and we all participate in the feedback process, and I'll describe that to you a little more later. And so I want to make that very comfortable so people will feel comfortable participating. And then at the very end of any training, I'm going to engage this process that I call eliciting change talk. So after we've been through the full training, and I'll show you what the structure of that looks like, it's got 2 rounds of MI expert facilitated role play with feedback and coaching. And so at the end of that, as we're closing out and debriefing and about to say goodbye, I will have everyone in the gallery tell, depends. If I've got a really large group, we probably won't do that. But if I have a moderate sized group, I will have everyone tell what was your number one strength in MI skills and approach today, and what did you learn about an area for improvement, and then what will you do? What's your goal going forward for how to work on that particular area for improvement? And notice that I didn't say weakness. I tell this to them up front. We are people in development in our MI skills journey. And even I, to this day, 25 years in, still have some things I'm working on and areas for improvement. It's not a journey that ends. It really requires constant evolution. And so I will tell them that, and the importance of realizing that these are areas for improvement and we all have them. So I also realize from this healthcare communication culture that there's really not an understanding of what we mean by person-centered communication, of which motivational interviewing is the most prevalent framework in healthcare. And so a few things that I've done along the way to really try to hone that concept in, and how important and evidence-based it is that we have role play cases with an actual name of a person and details about their life. And then we'll have pre-role play discussions for each person's turn, where they'll read that case out loud, this little paragraph of maybe about 4 to 6 sentences, and maybe any clinical indicators that are relevant to what's happening here. And then I'll ask, I or whoever the facilitator is, I'll tell more about that. I will ask them, what do you see as the primary top couple of motivators and barriers for this person? And so they're thinking about this person, and they're thinking about that. They're putting their mind into that. And I've found that to be a really effective evolution of my concern about that as a challenge for the trainees that I've worked with. I also work hard to normalize their struggles with MI skills. So I'll share with them, oh, okay, we're talking about closed-ended questions, and I will tell you that at least 3/4 of the healthcare providers, these 3,400 that I've trained, will struggle with closed-ended questions. They have been trained with it. It's been reinforced in their rotations, in their residencies, and in their practice settings, etc. So I try to normalize it, and sometimes I will even share some of my own epic failures in the past, in the early stages of my journey, just to help people feel more comfortable that none of us are perfect and we aren't expecting perfection. We're going to try to build confidence through small successes. And then that last bullet there is something that I've learned not only because of my experiences in training all these years with all these people, but also from my little bit of background in adult learning and educational psychology. And it's really important before throwing people into skills development or role play that we really are sure that we've done a good job building that conceptual basis in MI. Really need to spend some time on that and build some activities that kind of lead up to the independence of trying it out in a role play with feedback experience. So just some highlights of training. I'm going to give a couple of highlights, and then I'm going to talk about healthcare providers, and then I'll move over to show you some actual examples of some slides just really quickly to highlight a few points. And then I'm going to come back in to highlights again and continue on. I'm going to kind of weave in and out for a little bit here. So I typically, when I'm doing a training, I will start with a brief exposure to rationale via the evidence base. But I personally also have evolved my training, not just from experience and background, but also Miller and Moyer's in particular, 8 Stages of Learning MI. If you are not familiar with that, I highly encourage looking at that. I also am someone who's done quite a few modified Cochrane methods, systematic reviews of MI impact on outcomes in various contexts with the PhD students who have taken the advanced MI elective with me. If you want to know more about those, I encourage you to Google me. Click on my Google Scholar profile, and you can find the MI, most of them. We didn't publish all of them, but quite a few of them, I think maybe about 12 to 15-ish, have been published, and you can learn a little bit about some of the things I'll talk about there, because we often will look at the training, see what impact it had as to whether or not those studies reported or not training or adequate training, and it's often associated with how the outcomes are impacted or not. Anyway, Madsen had a systematic review of MI training, and Soderlund, Madsen, and others. And so these have been two great sources also of informing the evolution of my own training model. So it's important to know that Miller is just my hero. It absolutely disseminates, all that they're doing. He's given these great commentaries along the way. The 10 Things MI is Not paper, the Confessions from an MI Trainer, which I think was from 2010. That was just phenomenal. But he does assert in several places the importance of a minimum training would be a 2-day workshop. I mean, that really is the minimum that it should be in order to really expect to produce trainees who have at least a beginner level proficiency level, which is considered to be 90% MI consistent. So he also says it requires 2 rounds of MI expert facilitated role play with feedback and coaching, and ideally would also include follow-ups over time to reinforce and sustain these behavior changes in communication. Because I think we all will agree that, you can come to a training and without reinforcement, when we get under stress, we tend to revert back to old habits. In particular, I'm talking about that healthcare communication culture, which is not necessarily person-centered. So I've also learned the importance of adapting with client trainee needs. And I will tell you that my College of Pharmacy is a dual campus program, and we have been for well over 10 years. We have a campus, I'm in Auburn, which is on the east central part of the state. We're really close to Georgia, just an hour and 20 minutes from Atlanta. Our satellite campus is down in Mobile, right up on the Gulf of Mexico. So it's about 200 miles away. So we have been using Zoom to teach and train, including MI, for quite some time, going all the way back to that period of time, even before the pandemic. So when a client asked me, hey, we need to train 250 pharmacists across the country, can we do this virtually? And at first I said, oh, I don't know, it's communication skills. But then I realized I'm already doing that because it's what we do in our curriculum. So yes, we implemented that, I think, in 2018 and beyond. And it's kind of funny looking back to those days when nobody really was familiar with Zoom. And so we had to spend some time up front creating some familiarity with that. Or will this be in person? I will tell you that more and more with these trainings that I'm doing, more and more they are predominantly Zoom-based. You can imagine why. The efficiency, the cost effectiveness, more and more they're that way. And there are a lot of things I like about Zoom, like this. I can see your names. I don't have to memorize the name when I'm live and in person with a group. We can go out in the breakout rooms to accomplish everything that we need to do that's not group-based. So it really is very efficient. But I did recently travel for the pharmaceutical company that wanted to have their medical science liaisons trained in MI. That was something I did last month up in Connecticut, and they wanted it to be in person. So that's really the first in person, other than locally or regional things, that I've done in a long time. All the things that I've done in West Virginia, other than one CE program, have been in person as well. So based on what Miller has said in that previous slide, one day can be a training. It can be a training, but is ideal with at least one follow-up. I've learned this because sometimes I will adapt the training. They want to get their whole department trained, and they just can't have everybody out for 2 days. So they'll do one day for half of the group and then one day for the other half of that group. And so I will often adapt, and I have mechanisms that allow me to do that I'll tell you about in a minute. So I've done quite a few half-day trainings early on for the American Pharmacists Association. The things that I did for the American Diabetes Association clinical conferences were half days, and I call that a mini workshop. It's really not evidence-based as a training, but it does allow for a good conceptual build and a few key skills activities, and an activity that's known as real play, and we'll talk about that in a moment. So I often get contacted, will you come do MI training, or will you do an MI training for us? Sure, happy to. Tell me more about it. How much time do we have? Oh, just an hour over lunch. So I have to very politely say, well, I'll be very happy to do an hour for you to do an overview and maybe a little bit of interactivity and group discussions, but we wouldn't call that a training. I wouldn't even call a 2 hour a training or even a workshop. I think I would just make sure to characterize that based on the evidence base and what the experts say. I would characterize that as a presentation that may or may not have some active learning activities. So I just want to tell you a little bit about the training structure that has kind of evolved. This is going to tell you a little bit about what I do when I really do have 2 full days. I'm going to first show you this slide, and then I'm going to go out and show you a few of the slides that I actually use to train some of this, and then we'll come back to the rest of the structure of the training. So I start with reflection activities. People learn empathy by thinking about their very own experiences. This is one way to learn. So I have them engage in a reflection activity. Tell me about a health behavior that you're not currently doing, but that you know that you should, but you just can't quite get to it. As much as you want to, you can't quite get to it. And what are your top 1 or 2 reasons why you know you should? And what are your top 1 or 2 reasons that get in the way? And so I'll have them do that and just kind of think about that, and then hold that, because we're going to come back around to that with some interactive real play activities. And so the real play activities are something that I learned actually from Delia West. Some of you may know Delia. She's been in the MI space with exercise in diabetes for a really long time. We were presenting on a panel together with something for ADA, and she was telling me about, this was a long time ago, but about real play and the importance of that real play process, because it is great for someone to be able to focus on practicing that MI communication skill without thinking about the clinical, analysis that needs to happen with that. Instead, they're real playing it from their own real life context. So in this case, we use that your own challenge with a health behavior, their own challenge with that, to do some real play. So we spend some time with some rationale and evidence base for MI, because I find that a lot of people come into these trainings, oh yeah, I know MI, I've been doing this for a long time, and I know what this is, and they really haven't had any formal training, because everyone thinks that MI is intuitive. It's what drew me to it. It was intuitive. Oh my gosh, for somebody who comes from behavior science and teaching behavior theories and doing research that are theory-based, my gosh, MI just made intuitive absolute sense to me. It was very exciting to me when I was first introduced to it by one of my colleagues here very early on. So the thing is that I really feel it's important to give some rationale and evidence base. And I always start with the quote from Miller that you see in quotes there. I'm going to show you it in a moment, and tell you how I use that and why. But he says we tend to believe what we hear ourselves say in the preface for the book Motivational Interviewing in Healthcare, and really uses it as the rationale. So I'm going to talk about that after this slide. So after that initial overview of why MI and the rationale for it, raising awareness about the writing reflex is something I always do first or next in this progression, really early. Because all of us have a writing reflex to a greater or lesser degree, and most people don't realize that they have that. It's a real thing. It's a normal thing. You're not a bad person. It's well intended. It's just that when it's exercised in the wrong, I shouldn't say that, in a way that's not constructive, then it creates problems. And so we really want to raise awareness about all of that early on. I find that's a very effective way to get started before we even talk about the MI principles, micro skills, etc. And I mentioned to you, I don't really talk in acronyms with them. And so we also used example dialogues that people have different learning styles. Some people are visual learners, some people are auditory, some people are kinesthetic, meaning doing, and some people are predominantly combinations of those. So I'm always about trying to engage things that address the learning styles of various people. So when I have these example dialogues that I either have in worksheets that they'll be working through in a group or on their own, or I have this dialogue up on the slide so they can actually see it. We're reading it out loud, they can hear it, and then that can really help with that conceptual build that I was telling you is so very important. So just kind of stepping out of that sequence for a minute, I just want to really quickly just show you a few slides. I'm not going to linger, but I wanted to put them in here so that I think you're going to have access to the slides. I'm not sure about that, but I'm happy to share them if there's a way to make them available. So this quote is so critical. It really says a lot about what somebody needs to know who is just new to MI about how and why MI works. We tend to believe what we hear ourselves say, whether it's talking about making a change talk, or whether it's being the one to set that goal for how that's going to fit into my world. So if I were to tell you about trying to get more activity into my routine, I would tell you I had to gain some weight. I have a history of being very physically active, going all the way back, sports in my history. I was creeping towards the pre-diabetes range, etc. But, so there's the pivot. I'm so busy. I can't fit it in regularly. I've got responsibilities in my family. I've got a family business, and I've got a pretty demanding work life. So as I am telling you about why I know I need to get more activity into my routine, I feel this urge well up inside of me. And I feel almost palpably that I need to think about this. I need to figure out how to make that happen. And then when the but comes and I say, but here are the reasons why not, I'm starting to defend why I just can't get to this, then I can almost palpably feel that motivation deflate. So this comes from self-perception theory and some self-determination theory influence as well. We tend to believe what we hear ourselves say. This is really at the core of the philosophy of motivational interviewing and how it works. I can't tell you how many people have said to me, oh, I'm going to use MI to motivate that patient. Or I'll see programs, other programs or talks promoted with motivate your patients. That's just the so opposite of what motivational interviewing is. So this process of really embracing this and coming to understand why this is so important, even beyond the provider and the skills, but from what the patient or person brings to the table is really just so very important. So I always talk about the writing reflex, and I put this here because I'll tell a little story just to kind of normalize. We all have this. And some people in my family will tell you I have a roaring writing reflex, and I'll just kind of laugh about that a little, and it kind of puts people at ease. You're not a bad person because you have it. We all do. I think this is really important in helping people be willing to embrace that roaring writing reflex that we all do. So I just elaborate a little bit here on why it's problematic, and people get defensive when they feel violated, and it just does more harm than good. This defensiveness piece, when we violate either competence or autonomy, means they're going to either verbally or in their minds defend why they're not doing that, which is only going to reinforce why not. And so this is really very important. And I encourage trainees and students alike to think about focusing on, in most cases, to focus on eliciting change talk earlier before getting to problem solving and talking about what happened in the past. So what could you do? This is also strengths-based communication strategy. Sometimes it's essential to just get right to the problem solving and contingency planning, that is looking at what the challenges have been. Sometimes that is essential. But when one can, you can really build rapport by first focusing on what they could do going forward. So we also focus on the spirit of MI. I know there's no surprise there, but it's typically what I will do to contrast it with the writing reflex, and how evidence-based all of these components in the spirit of MI are for helping people decide to make changes. So I also add this little tidbit because I also teach and train some appropriately assertive communication in healthcare. Consult for that and have done some things with that just in and of itself. But I also have noticed among those I've trained that at least half use the language of your A1C or your blood pressure is a little high or your weight is a little high. And it's a strategy that is used to kind of cushion the blow of bringing that up. And it is not honest, and it's not trustworthy, therefore, and it conveys a discounting of that. And so I really focus on being direct in a kind and caring way. So your risk for diabetes complications with an A1C of 9 is high. The ADA guidelines, that expert evidence-based source out there, recommend an A1C of less than 7 to reduce these risks. What are your thoughts about that? So this is also something that I emphasize in the training that I do, just as an FYI, just because of what I have seen in this healthcare communication culture. So the rest of the structure of a typical 2-day training also includes first response to patient resistance statement. This is a little activity that we do. This is kind of the first thing they're really doing by themselves, where here's some resistance statements and what would you say first? And the reason that I do that is because I have seen in the trainees that I've trained, I've seen them just put up a wall and a look of deer in the headlights when the patient or the standardized patient, or however that is working, or the person playing the patient in the role play, is even a little resistant. They're not really sure what to do with that. And in fact, in the past, I used to survey or even just to interview in a discussion, what kind of conversations do you dread the most? And always in the top 3 was that patient who's absolutely resistant and puts up a wall. I don't know how to respond to that. I don't like confrontation. And so then I would ask, what do you usually do when that happens? And they said, well, I either change the subject, I just change the subject and move on to something else, or I end the conversation and walk away, in being honest. And so I realized that for most of us, and I include myself in this, if I just knew what to say first, then I feel pretty sure that I could carry the conversation forward. So I really spend some time here with an activity that's just simply early empathy and empathic reflection, even if it's a resistance statement, and then open-ended exploration. Tell me more about that, or what concerns you most. So that's a really important first step, and it's actually a worksheet. It's got all these statements on it. They may not be resistant. They may be just something really bizarre that the patient is saying. My mother's cousin's ex-husband said, that kind of thing. It might be something unusual like that can throw somebody off. So giving them the opportunity to really go through that exercise of thinking about and seeing themselves write down, so they get a little bit of time to write down that response. It's just a sentence or 2, maybe 3. And then we come back as a large group and we look at those and we share responses. And then I also will use example videos. a lot of my students or other trainees who we have videos or recordings of them in a simulated encounter from the past, gave me permission to use these. So I will do those, and we'll look at least one to introduce the feedback process. There are also some great videos online that are publicly available as well. And sometimes I've pulled a few. There's a great one from Rolnick himself talking with a man carrying higher weight who's come in for a hypertension session. It's a role play, a hypertension session, and then Rolnick wants to talk about weight management with him. And so it's really a wonderful, wonderful demonstration. And then we have what I call the transition cases. These are written dialogues. It has 2 or 3 exchanges. If we don't have time to do that in the course of a training, if I only have a day and a half instead of 2 days, this one I won't do live and in the training. I'll give it to them still as either homework till we come back the next day, or here's a worksheet for you to do on your own. There's 3 cases in there, and there's a little set of instructions for how they can have just a little piece of a conversation with that individual. There's something about actually trial and error and writing it or typing it in wordsmithing, that really goes a long way towards solidifying some conceptual basis before the 2 rounds of small group role play with MI expert facilitated feedback. So I want you to know that I've trained a lot of people in the model that I'm describing here, and students, even PhD students who are now in faculty positions elsewhere, students who took the advanced MI elective with me in the PharmD program and then facilitated in the role play labs for the junior students. Will come back and do some MI facilitation as well. And so the groups need to be 8 people or less in order to be able to fit 2 rounds in over the course of an afternoon. And so I'll just bring in as many facilitators as I need for approximately 8 member groups running simultaneously, if that makes sense. So we always debrief at the end with a change talk, a listening exercise I've already mentioned, and then sometimes there will be follow-up webinars that go along with that. And I'm always delighted when that evidence-based opportunity presents itself, just to reinforce. So just a few healthcare provider considerations that I've learned along the way is that that healthcare communication culture is trained and reinforced, and where I most commonly see MI challenges are in the 4 points that I've made right here on this slide. So expressing empathy. I hear a lot of I understand, probably as many as 2/3 of trainees say I understand. And so I statements, or even the I relate to that, or here's how I made that change. These are prevalent in healthcare across professions. And this is not empathy. Empathy has its own, standalone evidence base as this phenomenally impactful person-centered communication skill set and approach. And so it's important to be true to empathy and reflecting back to that particular individual, what is going on with them at the moment. So these are the 2 most common things that I say, that I've seen. And one thing that I will say is that I have noticed over time, because I've got these students for 3 years. I'm going to real quickly show you what that progression looks like in a few minutes. So I see this progression of the development of comfort level in motivational interviewing. And by the time they get to their P3 year, almost all of them, I would say all but maybe 10 or 15 of 150, all but maybe 10% are in the 90% or higher MI consistency rating realm. So I get to watch what happens over time. And I have found that the more that they practice expressing empathy, the more comfortable and confident they get with it. And then the more accurate they tend to be with the reflections of that person's feelings that we see. So I've already mentioned closed-ended questions being very problematic, especially for assessing readiness. Have you tried this? Would you do this? Would you consider this? Would you have you thought about that? All these closed-ended questions feel like an interrogation, and that is 3/4 of healthcare providers and students that I've trained struggle to let go of closed-ended questions because so much of the other interviewing that they're doing, the fact gathering, the taking a patient history, finding out about symptoms, etc., all are closed into questions because of the efficiency of that. And so it's hard for them to make the shift when we're talking about behavior change or knowledge gain to open-ended questions. And then responding to resistant patients. I think I've talked about this a little bit when I was talking about that one exercise that we do, but I also have come up with a little first line approach, second line approach, and third line approach that incorporates, the third line approach incorporates Miller and Rolnick's emphasizing personal choice. So I'm going back to just a few slides. I'm going to go pretty quickly through this. They're here for you. I call this expressing early empathy because it's often the ideal first response when a person expresses a strong emotion or resistance. And for those of you who come from counseling and psychology, you realize how extremely basic and elementary this is. But when you're training people who don't have that background to first get comfortable with even putting their toe in the water with this very important strategy, keeping it simple is really very important. So I just simply focus on direct reflections. I show them several examples of patient statement, and here's an empathic response. And then here are some, this is diabetes prevention program. I'm tired of having to write down what I eat and doing all these steps, only to find that it doesn't seem to make any improvement. And then practitioner, you seem discouraged, Mrs. Withers. So I do encourage them in person-centeredness to use the patient's name when they can, but not excessively. And then I kind of wrap it up with this, and I am telling them, avoid, I understand how you feel, and I tell about an experience that I had doing that when I was very early in my trajectory, and how I realized that I really offended somebody, and I have never forgotten it. It was an important learning experience for me. And then I'll say, so any of you for whom this is part of your vocabulary, I encourage you to think about ways that you could remove that from your vocabulary and just say whatever you were going to say after the I understand as a direct reflection, empathic statement. So just real quickly here, I think I've got really about 5 minutes left. So I wanted to tell you real quickly about this activity, because this is the first real play activity that we do, and it's expressing empathy. And I put them in breakout rooms, and I tell them this is just a portion of a conversation with somebody, and you're going to talk about your own health behavior, and you're going to be the person and the practitioner. And so the person is going to tell or to remind what their target health behavior is, what gets in the way of doing it, and how they feel about that. So for me, it would be getting more activity, I'm too busy, with detail, and then I feel discouraged and disappointed by that. So then the practitioner is just simply going to reflect back what the behavior is, what gets in the way, and how they feel about it. Now, again, very elementary, but for people who have never done this, this is doable. It's got a little script to it because we are just simply, it's a training piece here. And then we come back and we talk about that. What was your experience when you were the recipient of this as the person? And they're lighting up, and I felt, understood. I felt like I was important. And then what was it like when you were the deliverer of that empathic statement? And they'll talk about that a little bit too. So we'll talk as a large group about that. And I have just really implemented this probably in the last 2 or 3 years, and I feel like it's working pretty well, at least in getting people a little more comfortable with trying this, even though it's scripted. So here's another contribution from me based on my experience and those who don't like resistance. First line approach, express empathy and explore. As I demonstrated earlier, if they're still resistant, ask to share your concerns or worries, give the information. What are your thoughts about that? If they're still resistant, emphasizing personal choice. So I'm just giving you these so you can kind of see what this looks like. I'm not going to go over these because we need to kind of begin to wrap up shortly. And then there's the third line approach. Okay, and leaving the door open means after you tell them it's their decision, you might say, if you do want to talk about this at some time, I really hope you'll see me as somebody who would be happy to do that. And then I think probably you know about elicit, provide elicit. Establishing risk and susceptibility is something that I have called that first part, that tell me what you know or what have you been told. And a lot of my students, I've noticed, will embrace these open-ended questions to start the conversation for a specific topic. So just kind of an FYI about that. I'm all about conversation starters too. I love agenda setting, helps you build rapport while you talk about what they do want to talk about, so that when you get to the difficult topics, you've had a chance to build trust and rapport. And it's autonomy supporting and allows you even to be a little directive in getting topics out there. And then again, I just want to say, I also learned this from an MI expert in the academic detailing space. What are your thoughts, or how would you feel about? I really emphasize this because assessing readiness, other than through the ruler and other means, is a big place of challenge in the many, many people that I've trained. So giving them these starter stems, what are your thoughts about? How would you feel about? Rather than would you try, have you thought about, and so on and so forth. So for the students, similar to what we do, focusing on the literature. Really, I'm doing a lot in the skills progression process with them, and I'm very fortunate to be able to do this not just in one standalone course like we used to do it, just one course in the beginning of their first year, their P1 year, first professional year. And then they would not have MI again unless they took the advanced motivational interviewing elective course. So I also want you to know that MI, or person-centered communication anyway, patient-centered or person-centered is becoming a more prevalent term. To what degree has this become, because it's a nice evidence base, it's all over the guidelines, ADA standards of care anyway. Well, as of 2016 for pharmacy, this became a part of the accreditation standards in pharmacy education. Had to show evidence of doing something with motivational interviewing. I'm not sure how that is for the other health professions. So this just tells you a little bit about what we are doing. You can see that across the P1 fall, I'm doing in hypertension, diabetes and obesity, communicating with healthcare providers, literacy communication, cultural competence. All of these warrant person-centered communication. The smoking cessation module, and then at the end of the semester, they have their very first, they do a lot of real play and small informal role play until the end. In the smoking cessation unit, they'll do that transition case, the dialogue, and then they have their first formal facilitated small group role play lab with feedback and coaching. And we do that by Zoom. No need for expending resources to do that if we do it by Zoom. And a lot of the facilitators are senior students who took the MI elective or PhD elective and are helping facilitate. So then we come back in the P1 spring, comprehensive disease management. These are complex patients, 2 facilitated role play labs, and then their first assessment, which is the PBA, or formerly known as OSCE. And so on and so forth. Real quickly, combine it with shared decision-making training in P2 fall, and then they have in P3 spring another PBA, or formerly known as OSCE, with a trained standardized patient. So we assess MI proficiency with all of these students. We're aiming for at least a 90% target level. As I said, that's kind of the gold standard according to the MI training and assessment experts. Our model uses a measure that's built based on our model, the MISHKI, the Motivational Interviewing Skills and Healthcare Encounters. One of my former PhD students.
Jan, I'm sorry to do
Yes.
this. It's 2:02, and we have people that are signing off, and we really do try to start it in on time. It's been a wonderful presentation,
I'm
and
sorry.
I think we really need to wrap it if you wanted to say something in conclusion.
All right. I'm sorry about that. I really am. I get excited. I got off on these tangents that I probably shouldn't have. I had it on time when I practiced it, but I did put my email at the bottom of this slide here at the very end of the slide set that I'm going to make available for you. Please feel free if you have any questions or additional topics that you'd like to ask me about. There's my email. Look forward to hearing from you.
And just listening to your breadth and depth is impressive and exciting. Thank you for putting the energy and time into
Okay.
this.
Yes. Well,
Thanks,
thank you very
Jan.
much. And I'm sorry for going over the time. I
That's
apologize
fine.
for that. Yeah. Thanks
If
for
you could
having me.
forward me the slides, I'll share them
Okay.
and we'll have people communicate if anybody wants to reach out to you.
Okay. Sounds good. Thank you so much. Best wishes to everybody. I hope our paths cross again.
Thanks
Thanks
again,
again,
Jan.
Jan.
Very interesting.
Take
Very
care.
helpful.